Welcome to the show. I'm Caitlin Hope with Heather Murphy. And Heather, picture this NCLEX question. A nurse gives opioid pain medication, does not come back for the reassessment. The patient tries to get up alone, falls, and gets injured. The STEM asks, is this negligence or malpractice?
And that word reassessment is doing a lot of work there. Because once you said opioid, missed reassessment, and patient fall, I'm already thinking professional duty was attached to that nurse.
Exactly. Here's the quick lesson burst. Negligence is the broad idea. Failure to do what a reasonable person would do in a similar situation, or doing something careless that a prudent person would avoid. Malpractice is professional negligence. So, on an exam, if the bad act is tied to nursing judgment or nursing care, malpractice is usually the sharper answer.
Right, and malpractice has 4 components. I'm going to number them because students mix up the middle two. 1, the nurse had a duty to the patient. 2, there was a breach of that duty. 3, injury, harm, or damage occurred. 4, that harm was caused by the breach. No causation, no malpractice claim.
That fourth one, caused by the breach, is the part people skip. I had a new nurse once who wanted to chart like 3 paragraphs after a near miss. I told her, calm down. We still fix it, we still report it, but harm matters in the tort question. In our NCLEX scenario, the nurse had a duty to reassess after pain med, breached it, the patient fell and was injured, and the missed reassessment connects to the injury. That's malpractice.
And the source notes give classic malpractice buckets: failure to properly assess and monitor, failure to administer medications properly, failure to communicate, failure to act, failure to use medical equipment properly, failure to properly plan and administer nursing care, and failure to exercise ordinary care to avoid emotional harm.
Let me turn that into fast bedside examples. Not checking respirations after an opioid. Assess and monitor. Hanging the wrong dose. Medication administration. Seeing a critical change and not calling the provider. Communication. Bed alarm broken and you keep using the bed anyway. Equipment. Sending a confused high fall risk patient to the bathroom alone. Planning and administering care safely.
Okay, now flip it. Intentional torts are different because the act is intended. The notes say there must be intent to interfere, intent to bring about the consequences, and the act substantially causes those consequences. So NCLEX keywords matter here.
Yep, if you see intended, threat, restrained, private information, false statement, your brain should go intentional tort. Assault is a verbal threat. Battery is physical harm or unwanted touching. False imprisonment is holding someone against their will without consent or legal authority.
Give me the bedside version of assault versus battery because students swap those constantly.
Assault. If you don't hold still, I'm going to give you the shot anyway. That's the threat. Battery. Actually giving the shot without consent. Threat first, contact second. If nobody touches the patient, it can still be assault.
And false imprisonment. Say a competent patient says, "I'm leaving," and a nurse blocks the doorway or applies restraints without proper authority. That restrained piece should jump out.
Invasion of privacy is another big one. Sharing private information, posting patient photos, discussing details where others can hear, those are exam traps. Fraud is deliberate deception for unfair or unlawful gain. Defamation harms reputation. Spoken false words are slander. Written words or images are libel.
So if a nurse tells coworkers a false story that a colleague diverted narcotics, that's slander. If they post it online, now we're in libel territory.
That posted online piece sticks. Also, quick Board of Nursing reality check. Disclosing patient photos, chronic drug or alcohol abuse, criminal conviction, falsifying an employment application, misappropriating meds or supplies, those can trigger investigation. Different lane from NCLEX tort questions sometimes, but still very testable.
Let me do a rapid quiz. Nurse forgets to raise side rails after care and the patient falls?
Unintentional, likely negligence or malpractice, depending on the professional duty described.
Nurse threatens to tie a patient down if you won't stop yelling.
Assault.
Nurse shares patient lab results in the elevator.
Invasion of privacy.
Good. On the exam, don't just ask, was something bad done? Ask, was it careless or was it intended? That one question clears up a lot. Now imagine a student nurse getting corrected in front of everyone at the nurse's station. Why would you even think that was the right med pass? The unit goes quiet. That one moment can be plain incivility or part of something more serious.
And that scene is not abstract. Every nurse remembers some version of it. So let's separate the terms cleanly. Incivility is rude, disrespectful, discourteous, offensive behavior. Gossiping, spreading rumors, refusing to help a coworker, name-calling, condescending tone, public criticism. Bullying is more frequent, more intense, repeated abuse of power meant to humiliate, offend, and cause distress.
That phrase, repeated abuse of power, is the key token. One rude comment is bad. A pattern of targeted humiliation is bullying. And students sometimes normalize it. Well, that's just how the floor is. No, it is still harmful.
Yes, we do not get to call cruelty high standards. Now, the notes separate horizontal and lateral violence a little differently than students expect. Horizontal violence here includes top-down and bottom-up. Top-down is supervisors harming those who report to them, oppressive supervision, constant criticism, unrealistic demands. Bottom-up is workers or students being uncivil or bullying towards supervisors or educators, public criticism, social media bashing, overt rudeness, vindictive remarks.
And lateral violence is between equals, peer to peer, nurse to nurse on the same level, student to student, coworker to coworker. Same rank, same table, still harmful.
So, in our student scenario, public correction on the unit, what's the best response? Because I know what people want to do, which is cry in the supply room or clap back. I've seen both.
Understandable. But professionally, pause first. Protect the patient in the moment. Ask for clarification if needed, privately if possible. Then document what happened. Date, time, exact words if you can remember them. Witnesses. Report through the clinical instructor, preceptor chain, or unit leadership depending on the setting. Self-protection matters. Facts, not emotion-heavy summaries.
That exact words tip is gold. If someone said, "You are unsafe and useless," write that, not "preceptor was mean." Specifics protect you. And if it's a repeated pattern, reporting pathways matter more, not less.
You know what this connects to? End of life care, oddly enough. Because conflict gets louder when families are stressed and clinicians are divided. Medical futility means interventions are judged to have very little or no medical benefit, or the chance of success is low.
So think advanced illness, multiple failing systems, and a treatment that's technically possible, but not really helping. That's where students hear, "Why are we still doing this?" and feel the moral tension.
Exactly. Now compare palliative care and hospice. Palliative care focuses on comfort and support for patients and families facing terminal illness, but there is no definite timeline until death. Hospice gives comfort at end of life, when the patient is expected to pass in 6 months or less.
That's 6 months or less. I'm never not going to say it out loud. If the STEM gives prognosis in that range, hospice should pop into your head. If the patient has serious or terminal illness and needs comfort support, but not that defined prognosis, think palliative care.
Let's make it concrete. Patient with advanced illness, increasing pain, fatigue, family overwhelmed, but no clear 6 month prognosis.
Palliative care. Comfort and support now.
Same patient, now the team expects death within 6 months or less.
Hospice becomes appropriate.
Now the documents. A living will gives directions to healthcare providers about withholding or withdrawing life support if certain conditions exist. A durable power of attorney for healthcare lets a competent person designate someone else to act on their behalf if they cannot make their own decisions.
So, living will or advance directive equals instructions. Durable POA equals decision maker. That's the clean exam split. If the question asks, who speaks for the patient now that the patient can't, You're probably looking for the durable power of attorney. If it asks, what did the patient say about life support ahead of time? That's living will territory.
And when both exist, you identify the document, determine the patient's condition, and choose the response that protects patient rights and dignity, not staff convenience, not family volume, patient rights.
That's really the thread through all of this, from bullying to hospice to legal documents. Under pressure, do we protect people or do we protect our own discomfort? That's maybe the question I want students to sit with.
That's a good place to leave it. Thanks for being here with us.
See you next time.